Yes, before I go on, I think you've got to take off your relapse and your EDSS blinkers, because this disease is not about relapses and EDSS. It's about what you're going to look like when you get to 60, 70, or 80 years of age with the multiple sclerosis. So it's more about the hidden disabilities, first of all. And the second thing is, when I had the opportunity of talking, and I had to do this presentation in a few hours this morning, I thought I don't want to really discuss whether or not you can treat RIS or not treat RIS, or you treat RIS or you don't, because the fact that we don't have a disease yet, because radiologically isolated syndrome is not a disease, it's a pre-disease, means that we're not really able to treat it according to payers' guidelines, etc. And so it creates inequality. So if they went to, say, one of you who voted, I want to treat, that person will get treated there. They went somewhere else, they wouldn't get treated. What we really do need is consensus. And the problem we have is really with the diagnostic criteria, and I want to blame Bill Carroll because it's on the committee, is that they missed a perfect opportunity to change the diagnostic criteria to allow us to diagnose MS earlier and potentially offer treatment for people with active. And so when you do develop diagnostic criteria, and I'm going to fall back on some philosophical arguments, there's an underpinning from philosophy about how you create diagnostic criteria. There's a well-defined scientific method, how you validate the criteria, and there are obviously consequences which I'll discuss. And then I'll hopefully use an argument at a personal level to make you realize that if it was you at RAS, you'd almost certainly want to be treated with this. So I do have disclosures which are relevant because it's about treating the disease. And does RAS exist? So there's clearly an MS prodrome, which is probably pre-disease, and you probably saw this Helen Tremlett paper that came out last year using medical records in Canada. And what they found was, before somebody presented with CIS or developed MS, and you look back in the last 5 years, they were much more likely to see physicians, have hospital admissions, and receive prescriptions. So there's clearly sickness, real sickness behavior before you actually have your first event. So there is a period of time where people do have a prodrome. And the diagnostic criteria really define the disease when you present with your first attack, or you're disseminating time and space to get the diagnosis. What the prodrome does is potentially moves the diagnosis earlier, but what I'd like to argue is we want to move the diagnosis even further forward that way. And so this is kind of how I see the disease. Obviously, if you're a patient, or possibly if you're a physician, you see the disease in the pre-symptomatic or symptomatic phase, and the symptomatic phase is atypical, non-specific or specific, and this is the phase we treat. But from a classification system, if you're a regulator, in other words, licensing drugs, or you're a payer paying for these therapies, you only see this part of the disease. This is all irrelevant to you. Now the question is this part of the disease relevant to the individual? In other words, if you had prodromal MS or you had asymptomatic MS and you knew about it, would you want anything done about it? And that's the question. And so I do think it has a subclinical impact, and it's not so subclinical if you look for it. So this is actually an Argentinian study. Everybody in Argentina who goes to high school does exactly the same exams in years 8, 9, and 10, and then they leave. And what happens is that when people leave and they develop multiple sclerosis, you can go back and look at their grades in 8, 9, and 10 and compare them to an age match and sex match control group. And you can see up to 10 years after leaving, people developing MS or CIS, up to 10 years after leaving, they really took a cognitive hit 10 years earlier. So before these people actually have their first event, they're suffering the consequences at a group level of having cognitive impairment. And this is the same example from pediatric MS. By the time children present with their first attack, they've already lost significant brain volume compared to controls. So this disease has a pre-symptomatic, asymptomatic phase that can be decades. We all know about brain volume loss. The substrate for worsening or progressive disease is there from the outset, and it occurs at a similar rate across the spectrum of the disease. And almost certainly, if they had the opportunity, they would have put a radiologically isolated syndrome box there, which is identical. And that data's been done. So this is the Italian RIS study. And you can see normalized cortical volume, normal brain volume. There's the healthy controls. And you see the patients with radiologically isolated syndrome have brain volume loss. It's not dissimilar to people with early relapsing remitting MS. So they may be asymptomatic, but they've already got end organ damage. They're losing brain. This is actually an earlier study just looking at cognitive. By the way, in this particular study, this correlated with cognitive impairment, and about a quarter of these patients already had cognitive impairment in 2 domains. So they really are suffering from cognition problems. And in another earlier study, just showing you that when you look at patients with risk MS compared to normal subjects, you can see patients already are having quite a lot of cognitive problems. So I don't know if it's a benign disease. You may say it's benign in terms of relapses and EDSS, because that's the way we think about the disease. But if you were thinking of it from a neuropsychological perspective, this would not be called a benign disease. In this study, about 40% of these people had cognitive impairment. And this mirrors what we see in patients with CIS. This is now a little bit further along because you now had a clinical attack. In this particular study, over half the patients at baseline had cognitive impairment. So this disease is not benign. What worries me the most is that there's a significant number of people who go on with follow-up, and this is the Okuda study, following up that exact example, who come up with primary progressive disease years later. And so these people then miss out on having their sentinel event that brings you to your attention, and they come back 10 years later with their primary progressive disease, and you've missed a big window of opportunity to maybe modify the disease in that time. And this is an example of somebody scanned with tension headaches. 2002-4 follow-up, more activity, still asymptomatic, and they come back 9 years later with primary progressive disease. Now, if this was you, where would you like to be treated? In 2009, 2000, or 2002 to 2004? That's the question you really need to be answering. If this was you, where would you want to be diagnosed and treated? And this was a very worrying poster. This was presented at ECTRIMS by G10's group, taking radiologically isolated syndrome and just showing you that when you use a high sensitivity MRI, the lesions are pathological. They have a central vein. But more importantly, you see these rim lesions with these slowly expanding lesions. So these are the substrate, we think, that drives progressive disease. These are the slowly expanding lesions that have a rim of microglia with chronic demyelination. They get bigger. And data has been presented from the Oratoria trial showing that this is probably the most potent predictor of disability progression. And this lesion is not modifiable by almost all our disease-modifying treatments. And so the worrying thing is that when you look at the proportion of patients over here, 73, almost 3/4 of these patients already had these slowly expanding lesions in the asymptomatic phase of the disease. And if we're trying to prevent these from forming, we've got to try and modify the course of the disease as early as possible. So I'm actually for moving the diagnostic phase as far back as possible and trying to identify those people who are asymptomatic to see if they've got active disease to offer them treatment. And we've seen the diagnostic criteria evolve with time, and that has consequences. It changes the natural history. And the unintended consequences is that you change the natural history of this. So you all know Will Rogers. He's a comedian that lived in Hollywood around the time of the Great Depression. And he had this joke, when the Okies left Oklahoma and moved to California, they raised the average intelligence level in both states. This is called the Will Rogers effect. And so when you actually change the criteria from POSA, 2 clinical attacks, to McDonald, you can see the prognosis improves in both groups. And what that does is it essentially moves the more active CIS to relapsing, and it leaves the less active ones there. So both these groups improve in prognosis. This is well known. And this is what's happened, and this is why we can't use historical controls. So I have a different worldview. I don't actually like either of these. I think we've got to think about multiple sclerosis as being a biological disease. There's biology underneath it, and we should identify and diagnose the biology. And so the disease is the focal MS pathology because we think the focal lesion drives almost all the pathology of this condition. And so if we can identify this disease and we can show it's active, there's no reason why we shouldn't be able to diagnose it. And I don't think we need to change the criteria. We can still have the same criteria, okay? Same criteria. Maybe we want to improve the criteria and include Dawson's fingers and subcortical demyelination. But there's no reason why we can't actually say RIS is MS when there's dissemination in time and space. No reason why we can't. The only reason why a lesion is symptomatic is it occurs in an eloquent site. That's the only reason. So the science, and this is where I'm going to criticize the McDonald Criteria Committee, is they don't apply the science because there's a well-defined set of criteria for diagnostic criteria. Ideally, they should have a sensitivity and specificity of greater than 80%. Do you know what that is for MS, for the McDonald criteria? You've got to compare it to a gold standard. So what's the gold standard? So what they tend to do is they always compare it to the previous set of criteria or the poser criteria. So the gold standard is another set of criteria that have never been validated. Have the poser criteria been validated? No. So we don't know how good our diagnostic criteria are. The best study that comes out is the Danish Engelpo paper from 1988, where they actually did look at how good people are diagnosing MS. And those patients were probably diagnosed mainly with Schumacher at the time, rather than poser. And they weren't bad. The misdiagnosis rate was 6%. So the sensitivity there is about 94%, which is not bad. It's much better than Alzheimer's and Parkinson's patients. What about the sensitivity? How good are we with sensitivity? We don't have sensitivity. All we can use is Engel, because he was interested in MS. He found about 18 patients in people that had post-mortems for other reasons, that had MS at post-mortem but were never diagnosed in life. So we don't know how good the sensitivity, specificity is, So it could be about 25% missed. So until we know how good these diagnostic criteria are, we're in trouble. So I actually would propose we scrap them and we formulate new diagnostic criteria that allow us to diagnose the condition from a biological perspective. You may disagree with me, and I think we should start thinking from biology. We want pathology in there. We want central vein sign. We want subcortical demyelination. We want the oligoclonal bands. We do want the dissemination in time and space. I'd argue for EBV positivity in there because that is a ubiquitous phenomenon. I think we should then set up these diagnostic criteria, and then we should register patients in a natural history study so we can assess the sensitivity and specificity of those criteria. Anyway, this is a case, and it's not my case, because we run a preceptorship, and we had a group of South American neurologists, and this Dr. Zanger brought this case asking my advice. And this is an example of why we should treat CIS. So this was a 44-year-old woman. She presented with a severe headache and was found to have an aneurysm, sacral aneurysm in the intercarotid portion. So she had it treated, okay, and then post-operatively she had an MRI and it showed MS-like features. When she was examined after her aneurysm was stented, and the only thing they found was mild hyperreflexia in both arms, which to me is not a localizing sign. Visual acuity and everything was normal. So this was a person who had never had any symptoms, and her presentation in terms of the aneurysm was unrelated to her MS. Workup was negative. She did have delayed VEPs. And her CSF was positive with local synthesis of the band. So this lady had MS. She then was followed up for 3 years, okay, and she had MRI every 6 months because she was a private patient, so you do it every 6 months. Okay, she only had one more lesion in 2017, and then in 2018 she comes in with 6 new lesions and 4 of them enhancing with gadolinium, no symptoms. This is her scan. I don't think she's had MS for a few years. I think she's had it for a long time. You can see how much brain volume loss there is, and she's got confluent lesions. Quite a big lesion load. And she had several enhancing lesions as well. So the question is, we're debating, should you treat this lady or not? Should you just leave her? And that was the question they asked me, the advice, what would I do with this patient? So I said, go back and take a good history and examine the patient again, because you never know, you may find a relapse. I won't mention who. One of my colleagues says, Gavin, as a neurologist, you can always find a relapse. You mentioned the economics. So we know the economics is really, really bad, and it's linked to EDSS disability. So the lower your disability score, okay, the more likely you are to be employed. This is a European study. And I assume if we can take this extrapolate this back, the earlier you treat this disease, the more likely you are to stay in employment. We know the costs soar with disability, so the earlier you treat this disease and prevent disability, the better it's going to be economically. And we know quality of life plummets with this disease as you become more disabled. So the idea would be to treat risk to prevent disability. And don't exclude cognition out of this equation. Cognition is a big driver of unemployment. You can see at EDSS 3, no physical disability. Half those patients are unemployed. You think they're unemployed because of problems with walking? No, it's because of problems with cognition. Anyway, so this is actually the paradigm I've always subscribed to. If you can intervene early on in the course, your trajectory is going to change. And the sooner you treat this disease and switch off those new focal inflammatory lesions, you are going to prevent those chronic expanding lesions. You can prevent ongoing axonal neuronal loss. You're going to try and arrest brain atrophy. And your aim then is to maximize brain health for this patient. What you want is to get your patient to old age with a brain that's big enough, with enough reserve, okay, to deal with aging. That's the treatment aim of MS. And so why wouldn't you want to try and intervene at an earlier stage? And I'm not saying everybody. I'm saying if they've got active disease, if they disseminate in time and space and fulfill these new diagnostic criteria as having multiple sclerosis, because we need new diagnostic criteria, otherwise we're going to get people treated and not treated. Okay, why wouldn't you want to treat earlier? So in conclusion then, MS is currently defined clinically, which is the big problem. MS probably begins up to a decade before the first attack. The diagnosis is a moving target, okay? And it's currently not been addressed, in my opinion, by the McDonald criteria. This committee had an opportunity to let us diagnose asymptomatic MS, but they said no. Okay, I think we do need new diagnostic criteria. Okay, we need to redefine that as a clinical pathological correlate, apply scientific principles, and adopt a biological and not a clinical worldview of what multiple sclerosis is. I think in the future, though, I have little doubt that the DMF and teriflunomide trials that David mentioned will be positive because they're powered to be positive. And this is relapsing disease. I think economic arguments will be compelling. We need the maths and will improve as many DMTs will be coming off patent. So I think the idea that these treatments are too expensive, it's like everything else. When I was a medical student, statins were too expensive. You know, how could our country afford statins? Nowadays, statins cost maybe 1 or 2 pence a day. You know, every innovation gets cheaper with time. So I don't think we should use the economic arguments to stop people being treated. And risks of treatment need to be considered, but we can de-risk most of our current DMTs. Okay? And I must be honest with you, we mustn't forget about the dangers of untreated MS or undertreated MS. And I'm talking about risk being multiple sclerosis here, because it is MS. Okay? The best way to de-risk MS, okay, is to treat it. To leave it untreated is putting your patient at risk, serious risk, of irreversible cognitive impairment and all the consequences that come with that. So just remember, what this debate is really about, if that was you, that patient, would you want to be treated, or would you want to wait until you have your next clinical attack, or maybe come back 5 or 6 years down the line with primary progressive MS? So that's what the real debate's about. Thank you very much.